Hi, everyone. Welcome to our ACLP Virtual Journal Club. We're going to get started in about 2 minutes. Just give people a bit more time to log in. So thank you all for joining this month's ACLP Virtual Journal Club. I'm Monty Meyer. I'm one of the members of the ACLP Lifelong Learning Committee, and we sponsor this journal club series, which goes through different articles that are part of the ABPN continuing certification pathway and focusing on CL articles. So we're incredibly excited to focus today on celiac disease and neurologic manifestations from gluten to neuroinflammation. And this session's article will be presented by my colleague, Dr. Ash Nadkarni. Dr. Nadkarni is an assistant professor of psychiatry at Harvard Medical School and associate medical director of Brigham Psychiatric Specialties at Brigham and Women's Hospital. And Dr. Nadkarni has a clinical focus on caring for patients with disorders of gut-brain interaction and also inflammatory bowel disease. And additionally, she serves as vice chair for faculty enrichment at MGB Psychiatry, supporting workforce well-being and engagement. And on a personal note, I'm really very happy to have Dr. Nadkarni here since we have our offices next door and we get to work together every Tuesday at Brigham. So it's really a pleasure to have Dr. Nadkarni presenting on this important topic. And I'll turn it over to you, Ash.
Thank you, Dr. Meyer. So, very excited to be here today to present on this very interesting topic. Today, I will be looking at the pathophysiology and clinical manifestations of celiac disease, discussing the gut-brain microbiome axis and how that relates to the pathophysiology of celiac disease. We'll look at some clinical takeaways and also highlight some research gaps. So while I realize that the paper is one of the papers for certification, and there are probably questions related to a lot of the details within the paper, I'll try to focus on some practical takeaways for clinical care. So what is celiac disease? Celiac disease is a complex multi-organ disease. It involves the gut primarily, but it's got a high prevalence of extra-intestinal involvement, ergo why we're looking at this paper today and the neurological and psychiatric manifestations. It's an autoimmune enteropathy. So that refers to the fact that it's a disease of the intestine and it leads to symptoms of chronic diarrhea, abdominal pain, malabsorption, fatigue, and anemia. With celiac disease, at a core level, what happens is that people are ingesting gluten, and that causes their immune system to attack intestinal villi. So you have these classic GI symptoms of enteropathy and extraintestinal features. The prevalence is up to 1.5% of the general population, and more than 50% of adults do show extraintestinal involvement. Now, what is gluten? I think from a practical standpoint, it's helpful to discuss this. Gluten is a group of sticky elastic proteins, primarily gliadin and glutenin, and it's found in grains like wheat, barley, and rye. It's a binder that gives baked goods their chewy texture and structure. And if you're somebody who eats out, then you probably realize it's hard to avoid gluten when you're eating. So it can be a tough thing for people to have to restrict this when they have celiac disease. Now, what the paper goes into is that neuropsychiatric involvement in celiac disease really consists of ataxia, neuropathy, epilepsy, headache, cognitive impairment, and depression. From a historical standpoint, up to 20 years ago, the extraintestinal manifestation, these neuropsychiatric symptoms, they were initially linked to vitamin deficiencies, right? So B1, B6, 12, vitamin E. But now there's recognition that the neuropsychiatric manifestations are linked to this autoimmune pathophysiology and affects multiple organ systems, including the nervous system. And that is what really forms the basis for the extraintestinal manifestations. Now, neurological symptoms are actually uncommon in kids, but 36% of adults can actually present them. So let's take a brief look at the gut-brain microbiome axis and some practical pieces of this that relate to celiac disease. We now know that an imbalance of gut microbiota are associated with a variety of psychiatric diseases, such as schizophrenia, depression, bipolar disease, and anxiety. This is due to a result of an imbalance. That imbalance is called dysbiosis. And there are three types of dysbiosis when it comes to our intestinal microbiome. There can be a loss of beneficial bacteria. There can be an overgrowth of potentially pathogenic bacteria. And there can also be a loss of overall bacterial diversity. This can be characterized by an increased pro-inflammatory bacteria and bacteria involved in the metabolism of neurotransmitters like activated GABA. So that serves as the mechanism by which this dysbiosis is associated with neuropsychiatric disorders such as Parkinson's disease or autism spectrum disorder. Now, another piece of the brain-gut microbiome axis to understand is the concept of the intrinsic nervous system and the extrinsic nervous system. When we talk about the brain-gut microbiome, it's this network of connections that exists between the gut, the brain, and the intestinal microbiome. It allows for communications in this bi-directional way. So when we look at what we mean by the intestinal microbiome, we have all these microorganisms, the bacteria, the viruses, and the yeast. There's a gene pool there for the 3 known genes. And these gut microbiota participate in metabolism. The connections that the intestinal microbiome has with the brain specifically have to do with intrinsic plexus and the extrinsic plexus. So within our gut, it's interconnected, right? We've got this concept of the brain and the gut, and that's the basis for that expression, think with your gut. The enteric nervous system is what this is called, and it consists of all these sensory neurons and interneurons, and they've got these projections, right? They're called extrinsic nervous system projections. That includes sympathetics and parasympathetic efferents, as well as visceral afferents. That gut microbiota brain axis is this bridge between the intestinal microbiome and the brain. So I talked about those neuroanatomical pathways, but also those interactions are mediated by the neuroendocrine system. So the hypothalamic pituitary adrenal axis, also cytokines, and additionally indirect chemical pathways that can involve microbial metabolites and some specific neurotransmitters. So key point here is brain-gut microbiome axis. We've got the enteric nervous system, intrinsic plexus, the sympathetic and parasympathetic efferents and visceral afferents, extrinsic plexus, and this neurohormonal immune mechanism by which these pathways are forged. So this is going into a little bit more detail on that. The key point to understand here is there is a basis by which psychiatric disorders can actually alter these pathways and the signaling. because stress can actually change intestinal permeability. Let's take a look at that in terms of the intestinal microbiome and its role in celiac disease. In celiac disease, there can be an increase of potentially pathogenic gram-negative species and a decrease in beneficial gram-positive species. So you can sort of see, we're already seeing that dysbiosis and its impact here. And changes in that gut microbiome that can interfere with intestinal barrier permeability and cause it to become weaker. So this paper goes into a number of the specifics around the pathophysiology of how gluten ingestion really leads to neuroinflammation. The key point that you have to remember here is that transglutaminases 2 are this family of enzymes that are widely expressed in the body. And the problem in celiac disease is the body mistakenly views the transglutaminases 2 as an enemy and attacks it. So autoimmune mechanisms. That's what leads to inflammation of the gut. It leads to inflammation in the nervous system as well. Now, in individuals with celiac disease, you have this deamination of this gliadin modified epitope. And as a result, you get greater affinity for human leukocyte antigen in this antigen presenting cell. So this human leukocyte antigen 2 refers to these specific genetic markers in the immune system associated with high risk of developing celiac disease, but also type 1 diabetes. When anti-TG2/TG6 antibodies cross-react with normal tissues, you get this immune complex deposition and then neuroinflammation. So the gut-brain axis here and the intestinal microbiome evolve. So there's this concept of the gut barrier compromise, right? These toxins and these inflammatory markers are leaking into the bloodstream. There's also a gut-brain leak here, okay? This intense immune response makes the gut barrier leaky. You also have the concept of these markers translocating across the blood-brain barrier, causing neuroinflammation. And that's where the manifestations, that's where the neuropsychiatric manifestations originate. Sometimes these antibodies are meant to fight gluten, but they're attacking similar looking structures in the brain from herbs. That's the concept of molecular mimicry. Essentially, the immune system is getting confused and there's friendly fire hitting the system. So just drilling down a little bit on the mechanisms by which this widespread inflammation and autoimmune mechanisms really lead to the symptoms of celiac disease that are described in the paper. So again, right, like historically, it was thought that nutritional deficiencies were producing these symptoms, but what we now know is that have all these neuroinflammatory mechanisms and this molecular that happen. So what is actually happening from a psychiatric standpoint? You see cerebellar ataxia, peripheral neuropathy, seizures, headaches, cognitive impairment, depression, and anxiety. That can all precede GI symptoms. Now let's talk a little bit about what happens and how long, okay? The cerebellar ataxias and the neuropathy from a neurological standpoint are the most common manifestations, okay? So it's called gluten ataxia. And what you tend to see is a loss of balance, loss of coordination, lack of voluntary muscle control due to damage specifically in the cerebellum. So patients will present with unsteady gait, slurred speech, jerky movements, and headache. The other piece here is epilepsy occurring at a higher rate, 4 to 7%. So it's important to consider celiac disease in idiopathic neurological symptoms. Now, spanning the neuropsychiatric spectrum of headaches, which can happen with real severity, and brain fog, so concentration struggles, episodic memory deficits, word retrieval difficulties. And these typically do improve with a diet. Now, let's look at the psychiatric umbrella. Here, patients will have apathy, right? So we think of apathy as having those three dimensions: executive functioning deficits with planning or organization, emotional deficits with the flatness and indifference, and initiation, right? Goal-directed behavior, self-generation of action. Depression, anxiety, irritability, and symptoms. Those are the things that we really want to take away here from a psychiatric sample, okay? Because those occur most commonly in 20 to 40% of patients. Autism spectrum disorder and ADHD, there's some research that shows a higher prevalence and some association, okay? But the data are not as common here. And for schizophrenia and bipolar disorder, this is really just coming from a few observational studies, so it's considered a lot more rare. So it's not like, you see the patient with bipolar disorder and schizophrenia, and you should be thinking, oh, I gotta screen for celiac disease, okay? I would really focus on the top of this page: depression, anxiety, irritability, sleep complaints, and apathy. Okay, so the paper goes into, the biomarkers, the imaging findings. Transglutaminase 6 is this brain isoform that's expressed by activated astrocytes, microglia, and neuronal cells. So it's really critical in terms of the celiac disease pathophysiology and brain regions involved in regulating the cerebellum. Okay, so that's why particularly tends to be associated with this gluten ataxia. There are also cerebellar changes in the MRI. There can be EEG, a TMS changes, but there are technically no standardized biomarkers yet, specifically for neuropsychiatric symptoms. Okay, here are some findings that the paper goes into in terms of the EEG, evoked potentials, and TMS. So in EEG, you can get frequent occipital lobe abnormalities and increased risk of epileptiform activity that can be reversible with a gluten-free diet. Evoked potentials refer to changes specifically in central dorsal column conduction. In terms of visual EPs, that can be often without MRI changes. Generally, auditory evoked potentials tend to be more. And on TMS, there can be evidence of a hyperexcitable celiac brains, and these changes are specifically correlated with cognitive performance. This is going into, again, what the paper discusses, findings specifically on MRI with cerebellar changes and white matter lesions. Persistent autoantibodies are linked to progressive cerebellar atrophy. The overall implication here is that neurological involvement in celiac disease can be early, subtle, and reversible. And I'll talk a little bit more about that, how you really want to have an early diagnosis here, because sometimes changes are not as reversible. So as you can imagine, the treatment and prognosis really involves strict, lifelong gluten-free diet. So that's why I think that this paper is really valuable, because it's pointing to our role in psychiatry as we interface with patients who may present with extraintestinal manifestations and these GI symptoms, right? We too can have a role in screening and also diagnosing these patients. The neurological symptoms improve if treated early. Sometimes what can happen is that, if this neuroinflammation has been taking place too long, it can be hard to reverse some symptoms. Supportive therapy, I mentioned, right? There's an essential issue with absorption, so patients can have these vitamin deficiencies, or they can need rehab for neuropathy management. And interdisciplinary follow-up is critical. So let's talk a little bit about the clinical implications of disorders of gut-brain interaction and also the interface with celiac disease. We want to screen celiac disease patients for neurological and psychiatric symptoms. So if that patient has that history, we want to be determined, okay, do they have depression? Do they have anxiety? Do they have irritability, brain fog, insomnia, apathy? This paper speaks to the value of integrating both neurology and psychiatry into GI care. For IBD and disorders of gut-brain interaction patients, right? Like these are patients presenting with a spectrum of symptoms that are quite similar psychiatrically. So you want to consider potentially these patients gluten-related mechanisms. And it's also key to address the diet and intestinal microbiome factors too. So some key takeaways from this paper. We should test for gluten-related disorders with patients who have treatment-resistant depression or anxiety, right? Should you be screening for this in every patient who has depression? No, but they've got treatment-resistant depression or treatment-resistant anxiety. I think what this paper is implying we should consider it. And certainly get that screening history, right? Celiac disease is called the Great Mind because it mimics other disorders, right? I mentioned that the prevalence is up to 1.5% of the general population. But if you've got patients with autoimmune disorders, it might be worth it to really make sure you screen them. Okay, so for instance, you're a patient with MS, treating the patient with diabetes. I treat patients with IBD. It's definitely worth screening for this. Also, patients can have idiopathic neurological symptoms like the ataxia, the peripheral neuropathy, brain fog, very common. If patients have unexplained nutritional deficiencies, definitely important to screen as well. And remember to screen for patients with the psychiatric symptoms that are coupled with that GI distress, right? Those enteropathy symptoms of bloating, of diarrhea, of IBS-like symptoms. Let's also take a look at what it means to do the workup here. So when you screen, it's really a serology test, this TTG-IgA. That's considered the gold standard, but technically you have to check a total IgA to ensure the person isn't IgA deficient, which could potentially cause a false negative. Something interesting, okay? The patient has to be consuming gluten for this test to be accurate. So let's say, the patient suspects that they've got celiac disease, but they've been having this exclusionary diet for gluten, then in that case, you won't actually be able to test appropriately. And in that case, this HLA DQ2/DQ8 testing, that's used to rule out celiac disease. Okay. We should also consider this in terms of a differential diagnosis, right? Let's say you're consulting on the floors, you've got this patient who's got failure to thrive on the medical surgical unit. You really want to consider celiac disease in the differential. When you're working with registered dietitians, right, you want to ensure patients are not inadvertently given gluten-containing medications or hospital meals while under psychiatric care. And that's also a consideration too for treating our own patients with psychotropics. The other key piece here too is when you're treating these patients with psychotropics, there can be malabsorption, right? I mentioned there's damage to the intestinal villi because there's enteropathy here. So that can potentially affect psychiatric medication absorption, which means there could be reduced bioavailability. So in that context, you may want to consider a liquid formulation or potentially other formulations of medications, such as through the illness. Malabsorption can also lead to vitamin deficiencies, and those vitamin deficiencies themselves, right, can lead to depression, brain fog, and other considerations. Another piece of the malabsorption piece too, right, is that technically you could have a shortage of amino acids that you're absorbing. Those are some of the raw materials required for serotonin and dopamine production. So that could also impact mood regulation. So some of the future directions that this paper goes into is we need biomarkers for the neuropsychiatric piece. It would be valuable from a research standpoint to really clarify the exact brain-gut microbiome mechanisms by which the neuropsychiatric piece is emerging. We need to study the long-term neurological outcomes for patients who have a gluten-free diet and explore overlap with other gut-brain conditions. So to summarize, remember that celiac disease is a systemic immune disorder, not just a disease of the gut. Neuropsychiatric symptoms are common and they can really impact people's quality of lives. We reviewed some mechanisms that the paper goes into, including autoimmune mechanisms, the role of the brain-gut microbiome axis, the concept of the leaky gut, the movement of these toxins across the blood-brain barrier, and also the nutritional deficiencies and malabsorption that can contribute to these symptoms. And remember, the reason that I think this paper is so impactful is that screening and diagnosing these patients makes all the difference in the world because going gluten-free improves outcomes. So the more we know, the more impact we can have on these patients. Okay.
Thanks so much, Dr. Ned Carney. I'm already thinking about patients in my practice who have unexplained nutritional deficiencies and wondering if I should be working this up. So I think we have some time for questions. If those of you in the audience could put your questions in the Q&A, that would be great. And we do have a question here. I'll just read it out. Does microbiome dysbiosis and inflammation caused by gluten intolerance, not celiac disease, lactose intolerance, or processed food intolerance lead to the same neuropsychiatric symptoms?
Not that I'm aware of, like in the context of celiac disease, right? You really have this complex autoimmune mechanism taking place that can really cause these significant neuropsychiatric symptoms. Now, people may complain that they have some GI symptoms. I think we've all had a friend who insists that they've got gluten intolerance and doesn't want to eat gluten at a restaurant. But the neuropsychiatric manifestations really are specifically associated with celiac disease.
Thank you. And I also just had another question out of curiosity. Are there situations where someone might go on a gluten-free diet and their GI symptoms could improve, but their neurologic symptoms could persist?
Yeah, I mean, great question. Neurological symptoms in celiac disease may not improve or only partial improve, even with that strict gluten-free diet. Because delayed diagnosis can lead to irreversible motor or brain damage. Particularly, this is true for ataxia with the loss of coordination and cognitive decline. And that can be because the autoimmune response has permanent damage, right? The cerebellum can shrink, there can be nerve cell death. A gluten-free diet, unfortunately, can't reverse it. The other issue, too, is if you have a delayed diagnosis, right? You've got long-term exposure before the diagnosis is actually even linked to the irreversible neurological deficits. And some people may not completely heal their gut from that persistent inflammation or be able to stop that autoimmune reaction immediately. So that too can lead to ongoing symptoms.
Thank you. I was just reading that one of the big peaks for diagnosis of celiac disease in the US is still age 40 through 60, which I think is a really important thing for us to know. Like, not all these people are getting diagnosed in like childhood and adolescence. And I think as CL psychiatrists, we have a role in detecting that second peak.
Yeah, that's a great point. And you can screen with that tissue transglutaminase IgA test. And as I mentioned, it's paired with that total serum IgA test to ensure accuracy.
I see another question at this point. Is there any knowledge regarding the dose of gluten? So if someone is not gluten-free 100%, but maybe decreases intake, would it still cause the same inflammation? Is it dose related?
I'm pretty confident you have to have total exclusion in terms of the gluten-free diet, but I'd need to look into that more to make sure.
And then
Go ahead.
there's also a question about recommendations of effective models for psychiatric care in GI clinics, and if you have any thoughts on that based on your experience doing that.
Yeah, so we do have a clinic that is, I would say, technically co-located with with the Crohn's Colitis Center at the Brigham. That emerged through a specific research project that we did on recognizing that we were able to improve medical outcomes for patients with IBD as a result of psychiatric care involvement. I do think that it's helpful to have closer integration of care of psychiatry into GI as opposed to like a co-located model that you have. I think you can start that really by initiating a conversation with gastroenterology, um, and potentially having a consultative service where you see the patient as soon as they talk to them, because the challenges for patients who have disorders of gut-brain interaction, formerly called functional disorders, it's hard to establish a rapport as a psychiatrist when you're the very last person to see the patient. So what's worked better on our team is the gastroenterologist will evaluate the patients. Did we actually screen with patient-reported outcome measures in the Crohn's Colitis Center with PHQ-9 and GD7? If they pass that mild threshold, they actually refer them to us for initial evaluation. And we also collaborate closely with nutrition, with a mind body expert, and social.
Thank you. And then our final question is as to whether you know anyone in the Philadelphia area who specializes in this. Dr. Ned Carney, you may or may not.
I know that's a great question. I wish I did, but I'm just thinking to myself because there's definitely I know of a psychiatrist who specifically practices at Northwestern and at Cleveland. I'm not aware of Philadelphia. Sorry about that.
All right, well, we're at time. So thank you all for attending this very interesting talk. And thank you so much, Dr. Ned Carney, for giving us a lot of useful pearls for our practice. See you next
Thank
month.
you.
Take
Bye.
care.